Good morning, everybody, and very nice surgery shown by Dr. Arun. What I'm going to talk is surgery for keratoconus in extreme ectasia. You see a case of keratoglobus with a large ectasia. Usually RGB contact lens or any kind of contact lens fitting is not possible for these patients. Penetrating keratoplasty is not the answer because there's a graft host thickness disparity. So lamellar keratoplasty may be a solution, but what about the graft size and what about the limbal stem cell destruction that's going to cause along with it? So what I'm going to show you is a case of extreme ectasia where we did a large lamellar graft with flange tucking. You see this is, you can make out the ectasia even on this view. So I create a small side port and essentially do a 360-degree peritomy involving as much as the limbus involved, remove it, dissect it out. After the peritomy, we deepithelize the surface of the cornea. I'm using 70% isopropyl alcohol for this particular patient. And eventually now I'm going to create a gutter all around 360 degrees, wherein I'm going to push in the edges of the new graft that we're going to put there. So I marked out with a 11.5 millimeter refine over there. And this is the gutter that we are creating. This is a green super blade to create the initial groove. So I use a combination of the green blade and as well as the crescent knife to actually create this gutter or the space into which I'm going to tuck the flange of the graft, new tissue that I'm going to transplant in there. So the scleral pocket is created 360 degrees. I'll just forward the video. There are areas that are not adequately dissected. So here comes the crescent blade to actually deepen the groove to go parallel to the level of the sclera. So we have a good pocket wherein to tuck in the graft. So you can see how deep groove that we have over there. So here we put our tissue. It's not an optical grade tissue, but in lamellar keratoplasty it can be very forgiving and these tissues work extremely well. You see I passed the suture at a 90% depth through the graft and I passed it again into the groove and then brought out through the sclera. So I'm just washing the interface of the graft host interface for any debris. So eventually this is what the patient would look like, and I will so exactly this is what we have done. You can see that we created a scleral pocket. That orange part that you see over there is the sclera and the green is the new tissue. So we have created a pocket, put in the graft over the edges of the graft over there. It makes it more secure, and we've covered up the conjunctiva with the limbal graft, limbal tissue of the patient, original limbal tissue of the patient, so that we don't have any limbal stem cell deficiency. And you can see the pre and the post-op difference between the two different time frames. Thank you. Now I'm going to show you a next video on deep anterior lamellar keratoplasty using a different technique of viscodissection. Well, this case is very interesting. This is also known as Subota's technique. This is a case of keratoconus, not an extreme ectasia though, where radial keratotomy was done years ago. Essentially, why I wanted to show you this technique is we all see big bubble techniques and different techniques of doing DALC, but this is surprisingly has stood the test of time in my hands, and I find it extremely safe. So what you see here that I am actually just partially trephinating the center of the cornea, maybe about 7.5 millimeters. This is a Pufex knife, or you can use any straight lamellar dissector which is reasonably thin, and go straight into the stroma, entering from one side and coming out through the other. The idea is to do a very superficial dissection at this stage and debulk the cornea. What you see in the center, the white marks are basically cauterized ectatic cone, which I used to do a couple of years ago, not now. So once I reach the other side, so I'll just forward this video a little bit. So we just use a Vanna scissor to dissect the tissue into two halves. And now similarly, I'll be attempting to do the same thing on either side. The idea is to divide the tissue, the superficial stromal tissue, into 4 pies or 4 quarters, so that our superficial stromal debulking becomes more easier and safer. So just to take the Vannas again and snip it out, and you've got 4 pies by the end of it. And we can remove each pie one by one. And I guess that would be a reasonably debulked superficial stroma of this patient. Now to make a side port, inject air inside the AC. And again use the same Pufex knife. What I would like you to appreciate at this stage is, if I may, look at the tip of the keratome and look at the edge of the reflection of the meniscus. You look at the distance. The further away you are from the tip of the keratome, from this air meniscus, the shallow you are. The closer you are, the deeper you are. So my attempt here would be to reach as close as I can to this meniscus. And that will be very, very tedious. And tedious would be a wrong word. I mean, we need to be extremely careful. So look at this meniscus. We are pretty close to it now. So I'll just, for the sake of making it clear, the closer I get to that meniscus of air bubble, the deeper I am. So that's a very good guide for me to know the depth of dissection at this stage. This was initially described by Jarrett Mellis, in his initial publications on lamellar keratoplasty, rather novel techniques of lamellar keratoplasty. See, I'm almost approximating or very near touching that meniscus. So I'm reasonably sure that I must be pretty deep at this stage. So what I do now is I take a blunt iris repositor or a cyclodialysis spatula and create a pocket. But remember, the neck of the pocket should be narrow. I would create a pocket enlarging in the center, but the entry point of the neck has to be narrow. The idea behind that is I'm going to inject some viscoelastic through this port. Now if the neck is wide, the viscoelastic is not going to go inside, it's going to regurgitate back. So neck has to be narrow. You see, I go in with the viscocannula. So I'm using Helon in this particular case, but I usually use HPMC. So I've just dissected the posterior, the Descemet's membrane, from the remaining posterior stroma. You see the progressive extension of the area of dissection very gradually. And the most important sign that you'll see, you can still see a round air bubble. Keep an eye on that. The round air bubble will suddenly become sausage shaped, indicating that the Descemet's membrane has been pushed back and the air bubble hence get pushed to the periphery. Now notice that the eye is getting a little hard, so I might purge the anterior chamber and release the pressure. And now you can appreciate the sausaging of the air bubble. That is because your Descemet's membrane has been pushed back and the air has to go to the periphery. So I'm completing my dissection over here. So I'll just forward it a little bit. Keep checking the pressure. Unlike dissection with air, I'm very comfortable, but since there is Helon inside, there is not going to be any sudden rush of the Descemet's membrane coming onto the tip of your scissors. So it's pushed fairly back. I use the same technique of dividing it into 4 pieces as I debulked the anterior cornea. Your heart is actually in the mouth when you do this because you're really close to the Descemet's membrane. So we cut out the 4 pieces as I did earlier. And you can appreciate the air bubble now coming onto the center from the periphery because the Descemet's membrane has come back to its original position. And you can see how clean the dissection is. There is absolutely no stromal fibrils over there. And this video is perhaps way before type 1, type 2, type 3 air bubbles were described, and this was used to be my technique, preferred technique. So I'll just forward this a little bit. So you have the bare Descemet's membrane. This is the donor cornea. I usually use an optical grade tissue because in case of any perforation, I can shift on to doing a penetrating graft on these patients. So this is an optical grade tissue. I'm going to strip the Descemet's membrane. It's very important to be very gentle so that you don't tether the membrane into pieces. Then it becomes very difficult to identify the pieces. You see the stripping of the Descemet's membrane from the corneal stroma. I hate to see the good endothelium going waste. So we use the same tissue. There's nothing different in suturing except that we need to be extremely careful. The tip of the needle should not touch the bare Descemet's membrane when you're passing through the host. So do 4 interrupted and then a series of continuous sutures. Reform the AC with BSS, and I think we are done with the surgery. I think that's about it. Thank you so much.